Okay, welcome everybody. So we're here for our mostly weekly webinar series. We skipped last week because we didn't have a lot of new information, so we thought we would try and host these when we actually have something worth speaking to. Today was filled with a lot of different things going on actually, so the timing actually worked pretty well. You know, the plan for today is we'll go over some statistics again briefly. Most of you know all that, but we'll just sort of highlight some things that are relevant. And then I want to spend a fair amount of time talking about diagnostic testing. As many of you know, I've been encouraging folks to consider doing serologic antibody testing. So we'll talk a little bit about that versus the rapid diagnostic tests and some of the recent papers that have come out looking at comparing some of those tests. And then I want to spend a little bit of time talking about some of the treatments that have been most recently discussed, and obviously Remdesivir is sort of one that's being talked a lot about today. I think it's being overly optimistic, but we'll see. And then a few other treatments. And then also, as of today, I think it happened today, there's some shelter in place was extended, and there's some lifting of restrictions in the 6 Bay Area counties. So we'll talk a little bit about that. And then I would like to close with just sort of, you know, our own sort of self-care plan and what are we all doing to keep sane and keep active during this time, which has been, I think, a challenge for a lot of people that I talk to. So let me go ahead and share my slides, and give me one sec. All right. So let me just expand this out a little bit so you can see a little bit better. Great. So what I'd like to do is just start with, you know, where we were 2 weeks ago. And if you remember, it was roughly doubling every week. Every time we were hosting this webinar, it would double weekly. So things have definitely slowed down a bit, as you can see from this is 2 weeks ago, the 15th. And then if you move 2 weeks till today, it's about a 50% increase in cases, 2 million to 3.17 million cases. And if you look at the deaths, though, there's going from 133,000 deaths to 224. And the reason behind that, of course, is because of the lag time, right? So deaths come later since someone gets sick, and then takes 3 to 4 weeks until someone usually passes away. So that's still, you know, chugging along there. And then you can see testing for whatever that's worth in the US has gone from 3.1 million to 5.7 million, 5.8 call it, which is, despite what Jared Kushner, I just heard him saying, is really extremely suboptimal. So, and then thinking about just trending over time, if you look at what's going on now with new cases, you can see here, last time we looked at this, it was about 2 weeks ago, and it was just right around here, roughly a little bit before the 40-day mark. And things were still moving up with us. For example, now we're sort of coming along here. It's not like we're doing great. You can see we're still having a lot of new cases, but at least we're not increasing anymore. And then if you look at New Zealand, and if any of you have read in the New York Times and Wall Street Journal, there's some good articles about Australia and New Zealand. They've done an amazing job. You can just see, look at New Zealand just shutting the whole thing down, as well as Australia. Then, of course, you've heard a bit about some of the resurgence of cases. It's hard to know exactly what's going on in China, but in some other places as well. You can see Singapore and Japan, you know, we're doing well, and then they've had a resurgence. And so as we reintegrate, you know, how are we going to manage that? It's the other part of the equation. 2 weeks ago, I showed you this as well. And again, really the big take-home message here is, even though I think we're roughly 4 or 5% of the total world population, we're making up 1/3 of the deaths globally. So if people tell you we're doing a great job, you can see how that's not really true if you look at our per capita. And it might be, see one, do one, teach one. So when you role model certain behaviors, you may find that people don't do what they're supposed to do. I certainly know that as a father, as a doctor, as a professor, and the many roles we've all led in the leadership role. If you don't lead correctly, you've got problems. So this is a visit to the Mayo Clinic, and there you go. Despite, by the way, they asked him explicitly to wear a mask. So if you look at deaths, and you have 200, roughly, this is from the Financial Times, they're roughly the same proportions. If you look at here, they're saying 202,000 deaths. Look at the United States, we make up a fourth of all the deaths globally. I think that's just noteworthy, given the population size of America related to the rest of the globe. And if you look at the United States now, county by county, the darker colors being greater number of cases, you can see here that fortunately we've done fairly well in the Bay Area. For those that are from Portland, if you're watching this again, that you can see the slightly darker hue there, but the same sort of color as in San Francisco. Seattle did fairly well. Down in this region in southern Washington, they're having some issues, and over in the Spokane region, for those that are from Spokane, that are having issues as well. This hotspot here is Native Americans, so that you can see here outside of Phoenix in Arizona, that's the Navajo Nation and other Native Americans that are having quite a difficult time. A lot of UCSF has recently deployed 20 physicians to go to the Navajo Nation and work there and help support them. And of course, you have the tri-state area as well. And of note, Miami, if you look at the very bottom of the graph down here, Miami also is a hot spot. And within the Bay Area, the counties, this is the latest update of the counties surrounding the Bay Area and their deaths and cases. You can see sort of how things are trending here. 2 weeks ago, there were 65 deaths in Santa Clara, I believe it was. The number of cases actually has done fairly well in the increase, although Alameda still has a relative rise, as has Santa Clara. Okay, so those are the stats. I just wanted to sort of walk through those a little bit, and then move on to some conversations around testing. Everyone's talking about testing, but no one really defines what they mean when they say testing. So I thought we'd take a moment just to chat a little bit about that. So when we're talking about testing, there's a few things to talk about. So one is, do you have the disease? That's a different sort of test. That means, and I mean right now, like, do you have the disease? That test is typically done by PCR, and they typically take a swab and put it through, we've talked about this before, through the nose to the back of the throat. Some call it back to your brain, some of the news anchormen and folks, to the back of your throat, and have it there for about 15 seconds and then pull it out. Then they take that swab, put it into this medium, and they send it off for PCR testing, polymerase chain reaction testing. Well, it amplifies, if there's a little bit of virus in there, it'll amplify the number of viruses that are registering, so it can, while it's testing it, and therefore can detect even a low number of viruses. So it's a rapid test. It can be done at point of care, which some urgent cares are doing now, like Go Health, actually, which was formerly, I believe, Golden Gate. And that's for if you have the virus, if you're feeling sick or not feeling sick, and you want to see if you're infected. You've been exposed to someone, they're infected, you're worried you're infected. There's new testing coming out looking at maybe saliva might be just as good, might be even better. I haven't seen a lot of the data on that yet, but there's lots of conversation about that. Nasal swabs as well. As I mentioned before, there's a UCSF, UC Berkeley study that's going to launch. It's already started, I believe. That's doing the mostly actually the East Bay, and it's a seroprevalence study, and they're also actually going to do all of Bolinas, and the residents of Bolinas, and that's going to use saliva and nasal swabs for PCR, for virus antigen testing and using PCR. So that's to say, oh, do you have COVID-19? right now, are you infected with it? And I want you to keep in mind, this goes back to earlier talks that we had on 2 different occasions where I talked about this thing called sensitivity and specificity, which is really relates to false positives and false negatives. And what I want to say is that it's real important that that you have high sensitivity when you're looking for PCR. You don't, you want to get as many people as possible. And so you don't want a lot of false negatives, because if you are infected actively right now and you think that you're not, and you're walking around because you got a negative test, that's a problem, because you can infect other people. Now it's the opposite for antibodies. We'll talk about that in a moment. But that's real important. And there's a lot of false negatives. I just swabbed someone earlier this week and it came back negative. I'm pretty convinced she has it. And so we swabbed her again today. And often in repeated swabs. And if you look at some of these other studies, I'll show you in a couple of slides, you'll see that when they ran these antibody testing, they ran a group of people that had some respiratory antigen, they were PCR negative for this virus, yet they kept lighting up with antibodies anyway. And the odds are they were PCR negative, they really actually were infected. No one just could figure it out at the time. Then there's,
I was reading that apparently the saliva test seems to be a little bit more reproducible in terms of picking up some of these, quote, false negatives. It picks them up as positives. So the discussion is that apparently that the sampling, it seems to be easier, or the load is higher, the viral load is higher in saliva. So the hope is that it's going to be more reliable. Right. It's going to be picked up earlier in the infection.
Yeah, I heard the same thing. So yeah, if there's a higher, the thought is there a higher viral load in the saliva? That was the main thinking. And it might also be a sampling question too. Yeah. So then the other category of things is, relates to antibodies. What's that? That's your body's response to an infection. So you had the infection, or you were exposed to the pathogen. You may not have been, quote unquote, symptomatic, but because lots of kids will get this in young adults and not even know they really have it, that it's a slight cold or something like that. And then yet they develop antibodies to it. So that's a different category, okay? So just to repeat, we have PCR testing looking for the virus itself. That's what it's directed at, looking for the virus, and it looks at well, it's not worth getting it, but they're looking for the virus itself. Then you have antibody testing. So what kind of antibody testing is there? There's 2 different main camps of antibody testing. There's for the types of sort of processes through which they do the testing. One is using what's called lateral flow or capillary finger stick. So they do a finger stick off your fingertip, and you take some of the blood out using a pipette, you drop it onto this cartridge that I've shown you in the past on previous talks, and then it drips across, that's why it's called the lateral flow, sort of moves across this filter paper, and if it has the right, and if you have the antibodies, it lights up and says, yes, you have an antibody. It'll have a little band across it. And that, what does that tell you? It tells you that you have antibodies to this virus, in this case, COVID-19. That's the finger stick approach. And there's been a lot of variability in that. Let me hold that thought. The other approach is whole blood. And that's what I've been recommending patients do, is a whole blood test. So we draw blood from you. We spin it down to get the plasma where the antibodies live. We send it off to Stanford and Quest. At this point, I'm sending it to both labs. And I'm doing that simply because I want double confidence on the results that we get. If one's negative, but yet the other one's positive, that's helpful. And those tests are much more reliable. They have better sensitivity and specificity than these finger stick tests. So that's why we're using those. Now this paper just came out. I think it's actually preprint. It hasn't even come out. The article's sitting in someone's Dropbox folder that he's made publicly accessible. And the project's called COVID tracking. Let me switch it here for you. And it says this COVID testing project. And so these guys, also UC Berkeley, UCSF collaboration, these guys took 10 different companies and got their tests and then ran them against their own internal tests as well as another ELISA test. These ELISA tests are using whole blood. So these are these rapidly diagnostic test kits, RDTs. So 10 companies they compared. They had 130 samples that they could use the tests on. So they had 80 samples from people that they knew were PCR positive. Okay, they knew they had it. From that test we just talked about with the virus, yep, that person has COVID-19. They took 108 samples from 2018 blood samples. So they knew they didn't have COVID-19 because it didn't exist. And then they took 52 samples from people that had some known respiratory pathogen, and they were PCR negative, which could have been a false negative, but anyway. So what they found here was of those 10 tests, only 2 actually performed the way we wanted to perform. So there you have it. So, and what they found was the first take-home message is they perform best after at least 20 days after symptoms. So like I've said to several patients that have COVID-19, we don't want to do antibody testing for at least 4 weeks after your symptoms started. And ideally, 4 weeks after you're done with symptoms. But basically, 20 days after symptoms start actually gives you your best yield, because that's finally when you develop the antibodies you need at a high enough level for these tests to be able to find it. And then what we found was a range from 84% to 100% in specificity. And what does that mean? That means there was up to 16% false positives. So what does that mean? Let's just pretend that you had a prevalence of 1% in the population, or let's call it 2% of the population. And you had 16% false positives. That means that you'd get 18 positives back out of 100. Only 2 of the 18 would be real positives. 16 of the 18 would be false positives. That is a poorly functioning test. In a high prevalence situation where 80% of the population has it, that's different. But in a very low prevalent population, you really need high specificity. Otherwise, people think they were exposed and think they're immune and go out running around and actually will get sick. So their best performers with the highest specificity were these 2 that I listed here, as well as the third. But truly in such a low prevalence, you really want, so Sure Biotech and Wanfu, and these are ones based in Hong Kong and the other in mainland China. Then this one is the 2%. But again, if it's a 2% population, 2% prevalence in the population, and you have 2% false positive, half of your results are coming back are false positive, right? Because 2% are false positive, 2% of the population. So it's really important in low prevalence populations to have a really high performing test. Then the question that someone just posed is whether or not, if we do this 40 days out or 100 days out, how well do these perform? And what we know on the negative side is it's fine, right? So if you weren't exposed, you don't have the antibodies, it won't matter. If you were exposed and you do have the antibodies, how quickly do the antibodies wane? And all the studies I've seen, they've gone up to 39 days or 39 plus days, they'll say. So I don't have the exact data on past, month and a half, because they haven't really detailed it. But the thinking is, if you compare it with SARS or MERS or these other corona-like cousins, that the immunity itself is good for 2 to 3 years. So you think you'll have IgG, you should be positive for quite some time. To be determined exactly as we get more data. So let me pause and see if there are any other, Benardita, if you have any thoughts or if anyone has any questions or anything about the testing. I want to make sure we spend a little bit of time on that. I included the URL at the bottom, COVID testing project. They're going to continue to test more and more of these companies. And I've already reached out to Sure Biotech and Wanfu because they are well performing to see if we can get our hands on some. So is that, and then another person asked the question, if we have a positive from one company and a negative from another. So for us, if we're sending out to Stanford and to Quest, and we have mixed results, what do we do with those? I believe Stanford's more reliable. I'm asked both of them for their data because they haven't released their data. And I'm, in essence, doing an internal test of the two to look at the reliability of the two. And I'm currently using Stanford as the gold standard, given that they're an academic institution and they have higher quality assurance than a national private commercial lab at this point. So a follow-up question around this is really around, would it be good to test every 8 weeks? So this is an unknown. At the national level, people are saying you don't need testing, and let alone repeated testing. It's really, in my mind, on an individual level. So at a population level, we want to know serially if we're building more immunity, herd immunity over time. We're so far down on that curve within the Bay Area at 1 or 2%, whereas, for example, New York's at, we think, 20%, based on some of the data. And the Stanford statistics say somewhere between 2.5% and 4%. So serial testing is really up to each individual person. I think we should for the most part, assume that we're negative for most of us. And one negative, unless you get sick, you probably don't need to repeat it. But time will tell, as we get more and more data in the Bay Area and see what our true seroprevalence rates are, then we can decide how frequently we should get serial testing. I think for most of us, given our age, we will be symptomatic. And so we'd know if we got sick, if we got infected. So serial testing might be less of a requirement than I originally sort of posed in the beginning. But let's see how as time moves forward. Let me just see if there's any other questions. What is the test that Stanford and Quest is using? So they're doing these ELISA tests that we had up here, the 2 ELISA tests. So this, for example, the one at UCSF, they ran an ELISA test through their lab, and that's the and Stanford's using that same test. UCSF, I queried them, and their test isn't publicly available yet, and where Stanford has made theirs publicly available, which is why we're using theirs. They've been quite user-friendly as well. Great. Okay, so let's just spend a little bit of time talking about treatments. So this is updated from the last time I showed this, which was, I believe, 2 weeks ago. There are about 57 vaccines, I believe it was, being looked at, and I forget how many treatments, but maybe 2/3 of the number here. So there's an increasing volume of both treatments and vaccines. It's just amazing how quickly things are happening at a global level. And the amount of consortium and collaborations that are happening is just phenomenal. There's some early, there's a lot of sort of, I think, too early PR press around some of the vaccines. They're saying they're going to move. I think Pfizer said today they're moving theirs into, they may have one available for testing in humans at a large scale by the fall, they said. And Oxford University talked about theirs that's coming out. And so there's a lot of hype. I think, Benardita, you have a lot more experience around this space than me, but vaccines are moonshots in my experience, in my peripheral experience, and but maybe I think the ramp up time and the turnaround time on getting results might be happening quicker than previously, but my understanding is they're still moonshots. Benardita, do you have a view on that?
I just wanted to comment on the Oxford one because this guy's got results in monkeys. They tested their vaccine in 6 monkeys, which means that what they did was they inoculated the monkeys with a vaccine, and then they waited for the monkeys to produce antibodies. And then they challenged the monkeys. They gave the monkeys the virus. And they gave the monkeys the virus at doses where they had checked beforehand that the doses that were given would make the monkeys sick. And the monkeys were totally healthy. 6 out of 6 monkeys were healthy after that. So those were pretty exciting results, I think. Based on that, they're moving forward in clinical studies. But what's interesting is usually you start with a small clinical study, in the hundreds level. These guys are going to go into thousands of people right away. So when we're talking about, accelerating the process, everybody's doing things at risk here because they're not waiting to go to a small group and see whether they're getting antibodies, good antibodies in people. By good antibodies, I'm talking about antibodies that can block the virus. They're going immediately into a big study. I've seen numbers from 1,500 to 6,000. It depends on the press release that you look at. And they are going to immunize half of the people with this vaccine and half of the people with this investigational vaccine and half of the people with another vaccine, which is a meningitis vaccine, which is commercially available. So it's a blind study too. So it's really done, like a formal clinical study. So it's very interesting and exciting, I think, that they're moving so quickly. And the target is, they're expecting to have people get sick with the virus because the virus is in the community. So they have to have a certain number of people get infected, hopefully the ones that are not vaccinated with the COVID vaccine. And at that point, they can stop the study. So it can be, depending on how quickly that happens, anywhere from a couple of months to 6 months. It depends on how quickly the infection is going to happen. So I think that that's noteworthy. I'm kind of excited with that.
So I have 2 questions for you about that then. So one is they're going to have to identify emerging hotspots, I guess, to get the vaccine in so that they're
going to do it in UK. So I guess their statisticians must have calculated that with the infection rates that they have today, they're looking at months, maybe for, 3 to 6 months at the most.
And then the other question is around safety. I mean, normally,
what they're going to do is they're going to start this type of vaccine, which is an adenovirus vector vaccine. They have done it for MERS before. So they have experience already with about 300 people, injecting it in 300 people. So there's a safety base already with another genetic sequence, not with a spike sequence of COVID, but that sequence is very little, the impact that has in the overall structure of the vaccine. So what they're going to do is they're going to start with about 10 individuals that they're going to do very carefully at the beginning. So they're going to probably do those one by one or 2 by 2 and do a very thorough follow-up of 24, 48 hours, make sure there's no, reactions. Once they've done with those 10 individuals initially, then they're going to move forward with this kind of more broad and macro study of blind, injecting blind, some people with a meningitis vaccine and some people with this COVID vaccine.
Great. Yeah, that makes sense then. Okay. And so let me just go back to, let me just step back a minute because I realized I didn't share my screen for a moment. So let me just go back to, just for a moment, just before we keep going forward. Just to say that this was sort of the study. That's the URL if you're interested, called COVID Testing, the COVID Testing Project. And those were the companies in bold, Sure Biotech and OneFo, because I realized I didn't share this with you when I was talking about it. So that's exciting, and I'll look forward to hearing we'll know hopefully in the next, sounds like 2 or 3 months, Benardita, what from that vaccine trial, which should be quick. So that I feel like that's quite exciting. And then the other things that we've been talking to in the past, really, if you remember, this is a slide that we used last time, and now we're starting to see some results come out of these platform studies, where there are consortiums, large groups of folks, phase 3, multiple hospitals across the world working together on a single study. And these are various ones that are happening. So the NIAID, which we all know Anthony Fauci, who leads that institute within the National Institute of Health, recently came out with some preliminary literature. I couldn't find anything written about it. It's just sort of from a meeting where they looked at the data early on to get a sneak peek. Usually they do that for safety or early signs of success. But before we talk about that, let me just sort of, this is the medicine itself. It's for injection use only. So people are excited, but what people don't realize is this is when you're sick. Like, you only use this medicine when you're in the hospital. It's an intravenous medication. People do get side effects from it, although it's been pretty well tolerated, but it's for folks, you know, and it's IV. So the first study that came out, you know, I forget exactly when this was published, I believe earlier this week. So this study, which was done in China at 10 hospitals, took 237 folks, didn't show any benefit. They took people that were pretty sick. They had pneumonia by x-ray. They came in with less than 94% room air saturation. And they were given the standard dosing, that should have said 100 milligrams, not 10 mmg. So it's 200 milligrams day one, then they give 100 milligrams on the rest for a 10-day course. And they were permitted to be on these other medications as part of the clinical trial. That sort of, this is part of a larger clinical trial. There's other things going on. And also, I think with clinical care, they were giving lots of things to keep people alive. And they found no benefit in time to clinical improvement. That's what they were looking for by day 28. Now, they did see more rapid improvement among those that had symptoms for less than 10 days before they got treatment. The thinking there is, if you give them treatment earlier on, maybe they do better. Maybe before the cytokine storm happens, right? So if people get overwhelmed, if they're really sick, and this was a pretty sick group, so if they're quite ill and it's been quite some time, then it may no longer be, or at least it's exacerbated by our own body's response to the overwhelming infection, which is then we have our own immune response to it, what we call cytokine storm, for which there's treatments being looked at too. But maybe in that setting, we don't do as well. So they did say, based on this, you know, other research is worth looking at. This is published in Lancet, and I put and it was released, I guess, April 29th, actually, so today. So, and this is if those that are like to geek out on data, this is the data. This is sort of the take-home graph showing no difference. And there's a hazard ratio that crosses 1. So the confidence interval between 0.87 to 1.75, with the point estimate being 1.23. So if you don't have a confidence interval, you'd say, oh, people actually did worse by 23%, is what this would say. But the truth is a confidence interval. If you had 1,000 people in the study rather than a couple hundred, that confidence interval would be even narrower, and it might be 1.1 to 1.4 or something like that, 1.1 to 1.3, which means it would be actually statistically significantly causing harm, is what that would mean. But in this situation, the confidence intervals are quite wide, and it crosses 1, so it means no benefit, the bottom line. We didn't see any difference between the two groups. So now, we had this adaptive study that we heard about, you know, I just was trying to read about it today, trying to find some literature somewhere, pre-pub or something. There's nothing that I could find. But this is what we do know from just what was put out into the press by Fauci and others. It's a randomized blinded trial. That's what RBT means. So they're arbitrarily, randomly assigned to 2 groups. They're blinded. They don't know what medicine they're getting. There's 1,063 patients enrolled in the study at 68 sites. And And what did they found? So they found that people got faster more quick, they got better more quickly. So 11 days versus 15 days. And that appeared to be a survival benefit of 8% versus 11.6%, which is not overwhelmingly impressive, but is impressive. I mean, you know, you're dropping it by roughly, 25% of benefit and mortality benefit. So between the two groups. So we'll see how it all pans out, but this is their interim early findings. So there's been a lot of excitement about that. So, that is exciting. So then there's a follow-up on this, and this, I don't know if anyone has seen this, has gotten a little bit less press, but if you go to the Gilead website itself, they're releasing some early data saying that they did a study looking at 10 days versus 5 days of treatment. And they're showing that actually it appears to be no difference between the two on day 14. So that's exciting. And the reason it's so exciting is that there's limited supply right now. So now all of a sudden you have twice as much supply. So, and that's pretty much what they said actually in their press release about this. Now we could, double the amount of people that we can treat given our current limited supply. So that's also interesting. And you can see here, similarly, no difference. So let me just, the next thing I wanted to sort of allude to or just talk briefly about is just what else is out there. And I showed this to you last time, and this relates to the fact that there's consortiums coming together to create an unbranded treatment that they sort of would say, this is not, I don't own this, we're collectively creating this together as a consortium, which is phenomenal, which never happens. And then if you look online at clinicaltrials.gov or these other sort of websites that look at clinical trials, you can see, like right now, for example, there are 18 trials just looking at convalescent plasma therapy against COVID-19. So there's really a huge number of trials ongoing right now, and which is quite exciting. Another one that people have been speaking a bit about is this Pepcid study, and it's an interesting story. I mean, there's a guy who's an infectious disease guy, I think out of Maryland, who sort of hunted down and found some early signals around this. I don't know exactly how he originally figured out to look at this, but he ended up going through a whole bunch of patient records out of China, and he found that people on famotidine, which is used for reflux and sort of irritability of the stomach, were appearing to have not die as frequently as those that weren't on the drug. So 14% mortality rate versus 27%. This was, not a well-honed study. They didn't control for all sorts of things, and it wasn't statistically significant, but it was a signal. So he went back and grabbed some predictive modeling guys and started to model this out, looking at certain genetic sequencing of a range of different medicines. And again, it popped up again, showing famotidine as well as several others that came up as potential treatments. Based on those two findings, they started to do a clinical trial, and we're going to enroll close to 1,200 people is the current plan. And right now they have 187 that are enrolled in the study, looking at a drug that's quite, available, quite cheap, and quite interesting. So, at the end of this interview with him, McKellen said, while it's important to have amazing clinical scientists and researchers doing this work, nothing can beat the experience and wisdom of Chinese doctors who suffered through thousands and thousands of patients, and all that they learned in that process, which was really quite interesting. So other things just of note, so I talked about that cytokine storm, and where the body is trying to fight the infection that has this overwhelming response to the infection, which causes its own problems which can lead to multi-organ failure and many other problems, ultimately leading to death in many people that have this huge event. Or the body finally sorts on its own to quiet itself down, and then allow, as our antibodies emerge, and it sort of takes over and it is able to control the virus. This is a medication that is an IL6 inhibitor, basically. It sort of tries to shut down interleukin-6, shut down that overwhelming cytokine storm. So there's a lot of trials looking at that, and there's at least one study that I know of looking at high-dose intravenous vitamin C also, which is also quite interesting because I saw some early signals of that in China. So let me just pause for a moment and just see if people have any questions, or Benardita, if you have any comments.
Yeah, I had two comments. One, in the same vein of the blocking the immune response, there's another drug also that's an interesting one, I think, it's an Astra Zeneca drug, which is called Calquine. And it's a drug that basically blocks a kinase that is needed, that basically decreases the synthesis of the cytokines. So it may be an interesting one for the cytokine storm. And they are already in clinicals with that. So I think we should see results soon. And the other thing that has been in the news, which is kind of anecdotal and interesting, is the nicotine patch. Have you seen that?
No.
You know, the same, they did some retrospective studies, the same as they did with the Pepcid, with the famotidine. And I really need to look at the data, but what I've been reading is that they're seeing that percent-wise smokers are represented in low numbers in terms of the total numbers of smokers. I mean, what they're seeing in people that are getting really sick, percent-wise, it's low. And what they think is that maybe the nicotine has something to do with the blocking of the binding of the virus or something like that.
I'm gonna have to look that one up.
Yeah, so they're talking about maybe, using nicotine patches or something like that, and testing with nicotine patches.
Interesting.
So that's an interesting one. I just started to look at the literature yesterday, so I don't know that much about it, but I thought it was at least curious.
So someone else asked about stem cell treatment. Have you heard much about that?
Which one?
Stem cell treatment as being helpful for treatment and lung repair.
No. I haven't heard.
Yeah, I'll have to look that one up as well.
Yeah.
I guess let me just see if. So do you have any other? Let me just ask the person who's asking the question. Great. So I think over this next month, we'll definitely see a lot more treatments coming through the pipeline now, because so much was started in all those platform studies that I described earlier on are going to start to get lots of more results. So it should be quite exciting to see that part as we start to actually get results so quickly. And this is unheard of. I mean, part of the reason why I've been frustrated with doing clinical research in my journey when I was in academics is because things would take 1 year to 2 years to actually start. You get the grant, you run the study, you publish the study. There's a huge turnaround time. This just breaks all records, and hopefully this will help shape how we do clinical research moving forward. Actually, is one of the beautiful things that may come out of this. Great. So let me move on to the next subject area, which is sort of on top of mind for all of us. And I don't have any answers to this question. I have some thoughts, but it's really about about reintegration, and what does that look like as we come back into what's our new sense of normal, the new normal, sort of, as they said, BC and AC, before Corona and after Corona. So as you may have heard, you know, there's lots of people that are showing up on the beaches, like Santa Barbara had thousands of kids on the beaches apparently recently. And, you know, how do we do this in a sort of more staid way? Now, as of today, I believe it was, Gavin Newsom and in the Bay Area sort of health departments announced that they're going to extend the shelter in place through the end of the month of May. And at the same time, also have new orders on lifting restrictions for several kinds of businesses, typically outdoor businesses and outdoor activities. What might that look like is sort of the next question. What they really, you know, focused on is construction work, for example, real estate transactions, which is an interesting one to call out explicitly, clearly for economic reasons. And then some businesses that mostly, you know, operate outdoors. So, you know, what some of those might look like are, for example, you know, flea markets, landscaping, gardening, car washes, you know, so nurseries, of course, they have to practice social distancing, meaning that everyone has to still stay within greater than 6 feet from one another. But they're allowing these now to actually start to reopen. And they explicitly said, you know, restaurants, bars, nope, even if you have outdoor seating. So they're trying to stage this. They talked about children can meet in groups of 12 or fewer for recreational and or educational purposes in childcare or summer camp settings. So it's sort of trying to think about what that looks like moving forward. I know for my kids, for example, are supposed to go away for summer camp. Is that happening? Is it not? I know the summer camp thinks it's going to happen. The question is it, you know, what would that look like? And then I'd like to have a conversation about that actually on the backside of this with all of us, which is, you know, there's different ways to reintegrate. So I'll speak to that in a moment. And then they list out here outdoor recreation like golf, tennis, skate parks can resume. Although I read somewhere else that golf clubs can't resume. So it's a little mixed for me right now. Things that require person-to-person contact, for example, basketball, it's not being permitted, or if you have to share equipment, things like, you know, there's some common sense, but it's real important for all of us for it to be explicit, because one person's common sense is not necessarily someone else's. And then low-risk businesses like manufacturing and offices that, if they can implement social distancing, could reopen within weeks, they're saying. So, and then after that would be, of course, gyms and hair salons and things like that. So quite exciting. It's going to be an experiment in real time. And they have certain markers that they plan on actually tracking, and, you know, new cases, increased testing. There's a range of things they're going to do so we can track how well this is, how well we're able to do this, and at the same time not risk increased infections. So it's sort of a real-time play of what we're doing. Now the hope is that we increase contact tracing personnel and staffing. So if you think about it a little bit, you can do this, and this is where I want to talk more about. And if you're interested in sort of a couple of interesting pieces, one of my colleagues, David Katz, who's at Yale, who's the former director of the prevention health group there, wrote an op-ed in the New York Times, which got picked up, of course, by Fox News, because it was, he talks about reintegration, and but he talks about it from a different perspective than Fox News' objectives were. But he was also on the Bill Maher show, which really says, how can we do this in a way that's responsible? So how can we do it in a way where those that we know are going to do well get exposed and get infected and move on, and so that we can move towards herd immunity? So what would that look like? I've heard that 35-40% herd immunity may be sufficient. You know, if you look at measles, you need more than 90% because they are not, meaning their infectiousness. If I get measles, I can give it to 15 people. It's so infectious that you need everyone basically to have immunity. Otherwise, those that don't will get infected. with this one, if you do social distancing and you're able to keep the R not below 1, then the question is, what does that look like? And can we actually allow those that aren't vulnerable, the under 30-year-olds that are healthy, to reintegrate and start doing their return to their normal routine, and then take those that are vulnerable and sequester them. And what would that look like? And so because what happens now, if we get a vaccine, okay, great. But short of a vaccine, we've got a real problem with restarting our economy in its formal fashion. And because we're nowhere near herd immunity right now. And so if we have a resurgence in the fall, we're back to square one all over again. And now, with that said, how do we prevent this explosion from happening? If you're testing everyone, if you're screening them, so let me start with if you're screening them for symptoms, including fever checks, and then you're able to quickly test people that you're concerned about. And then once you diagnose someone, you're quickly able to figure out who they've been with historically in the past week. It's called contact tracing. Then you trace all those people, you do the same thing with all of them, you're quickly able to contain the spread of an infection. And so it doesn't become an epidemic or a pandemic. That's what we do all the time for sexually transmitted diseases, for example. That's been in place forever. Now, unfortunately, it's been always understaffed. And so we need 100x or 1,000x the current staffing that we need now. But if you think about the 26 million or more people that are unemployed right now, this could be a national level job program where people that are unemployed can get trained in contact tracing and work for the public health departments and do public health good. So that is a path forward. It's not being discussed right now at the level that it should, but pieces of it are being discussed. And I'm open to comments and people's perspectives if they have them. Does anyone have any concerns, strong concerns, or other views? Because the current national dialogue is one in which we're not having this conversation. It's just about, we're going to open our businesses when we can, and we'll have a vaccine. If we don't have the vaccine, is where we really have a problem.
It's going to take a while to get the vaccine anyway, regardless of how advanced we are. So we're going to open up, and we're going to get focus of infections regardless. It's going to happen. There's no way that it's not going to happen.
Yeah.
So.
Yeah, and so to get everyone vaccinated, even if you have, to your point of view, if you have a good vaccine that's proven to be safe, proven to be effective, and now you got to give it to everybody across the nation.
It's going to take a while.
Yeah. So then the other final part I just want to, speak to is our own mental sanity, and the importance of our sanity. And so the question I sort of want to put out for us to discuss is how easy is it and how frequent is it for you to get outdoors and to make use of the outdoors? For those that live here in the Bay Area, the outdoors is so accessible to us. And what many of us end up doing, for the most part, is we're all in our home offices. So we get up early and we sort of sit down, for those that are working, and they're immediately on the computer. And then you find yourself, not moving far from that seat in front of your computer. And so I encourage you to really think about how we can build into your own routine and your own calendar a time to reflect, time to go outside and go for a walk, time to exercise, time to sort of be in nature, and how important that is. So I just want to sort of go back to our own self-care and recognize how important that is. And I will say another important piece really around if you do get COVID-19, how well you do is our health, right? So we know people with hypertension, we know people with diabetes, people with lung issues, they don't do as well. And we'll tease this out more and more as we get more and more data. So the healthier we can become, the healthier we run our system, if we do get infected, the more likely we'll survive, the more likely we'll do better. So and if the sort of common sort of denominator of common sense, just to say, you know, of course you'll feel better if you exercise and find time to meditate and find time to take care of yourself and find time to eat well, isn't sufficient. If I can scare you from the COVID-19 infection side of the coin, I'll do that, whatever lever I can pull. But it's true. And what actually David Katz had said, who's a physician colleague I mentioned earlier, is he said, you know, with chronic disease, things happen over decades, and we're not really engineered teleologically to think about things over decades. If someone tells you you're going to have a heart attack 20 years from now, you need to stop doing something now, you're going to move on. For example, when it comes to smoking tobacco, what happened? People would say you're going to have heart disease, lung cancer 20 years from now. It was hard to convince people, but when you told men they would stop getting erections in the next several years, if they kept smoking tobacco, actually people were quitting a lot more quickly. So similarly, in this case, COVID-19 is revealing our vulnerabilities. At the system level, revealing our vulnerabilities for our preparedness for a pandemic, as well as at the individual level, saying those that are morbidly obese, those that have diabetes, those that have high blood pressure, which, as you know, is rampant across America. We in the Bay Area do a fairly good job at the population level, but it's rampant, is really revealing our vulnerabilities, and those people are much more likely to die or not do as well. So I just want to sort of call that out to you, to just give some thought and some reflection for your own well-being, because being indoors is hard. You know, it's hard to stay locked in, as we all know. So at this point, I'll bring it to a close, but it is 5 o'clock. If there's any other questions, maybe spend a moment and I can answer some of them. So one question asked about Sweden and Denmark and so their approach and how they've done fairly well. Now, and I'll tell you that they have a different sense of citizenship and belonging, and they are much more socially conscious. So they're not quite as individualistic as we are in America. So even though it was a voluntary lockdown from the social distancing side of things, a lot of them took it upon themselves to behave accordingly and act appropriately for the societal good. With that said, you know, they also did do a modest version of lockdown. So they did, I forget now, I'm blanking on the schools, but I believe it was either universities or grammar schools that were kept, was it universities that were closed? And so yet, you know, they allowed people to go to school, the younger ones, they allowed certain aspects of operations of business to take place. So they did do a modified version of what we're doing. And there's a lot more societal good. Now, and I think, again, logically, that is the right way to go. I think that will build herd immunity. You need to think about the aging parents with the young kids that are going to school. We have to figure that out. But for example, if kids are going to university and you can keep them at the university and you can wait to test them before they go back to be with their families, that's a way to sort of provide the insulation, you know, and sort of screening that we need to sort of weed out those that are more problematic. Well, thank you guys for being here and for your time, your questions, and we'll do this again next week, assuming there's a lot more to share. And we'll look forward to talking to you next time. And thank you, Benardita, for sharing your thoughts and input too. Yeah. Okay. Bye-bye for now.